Good afternoon, everybody. Thank you for joining today's webinar. My name is Nastasia Walsh. I'm the Associate Program Director for Justice at the National Association of Counties. I'm going to be moderating today's webinar. I want to thank the Bureau of Justice Assistance, Arnold Ventures, and NACo Smart Justice sponsors for support of the webinar. Some quick logistics before we get started so everybody can view the webinar correctly if this is your first one. The webinar is being recorded. It'll be posted on both the Stepping Up and the DataDriven Justice websites within about 48 hours or so for future viewing. You'll also receive an email within 24 hours from now with a link to the webinar recording and some other helpful links as well, so keep an eye out for that. Up on the screen, to the right of the screen, you're going to notice there's a control panel, and in the panel there's a questions box. You can use this box to type in questions or at any time to send us a message if you're experiencing any technical difficulties. If you are having any technical problems, we'll respond to you privately in that questions box. And then if you have content-related questions, we'll do Q&A after both of our counties have had a chance to present, and I will read the question on your behalf. But please feel free to start sending us questions while people are still presenting, and we can get to those at the end. So as you all know, because you registered for this webinar is a joint venture between the National Stepping Up Initiative and the Data-Driven Justice Project. So I want to talk about each of those quickly. I know some of you were on the last webinar when I talked about these, but we have a lot of new folks, so I'm going to go through them again. So first up is Stepping Up. So Stepping Up is a national initiative to reduce the number of people with mental illnesses in jails. And Stepping Up is a partnership between the National Association of Counties, the Council of State Governments Justice Center, and the American Psychiatric Association Foundation. We were launched in May of 2015, really as a way to elevate this issue of too many people with mental illnesses in our county jails. When we launched a call to action where we requested that local governments pass resolutions to formally join the initiative and to commit to really making a difference in their local communities. And so since that date, we have more than 500 counties across the country that have joined Stepping Up. We have counties across 43 different states, and we have I think the smallest county is about 2,000 residents, and the biggest county is 10 million residents, and we have everything in between. We are still accepting resolutions from communities that are interested in joining the National Stepping Up Initiative. So we would love to have you be a part of that. If you don't know if your county is already part of it, there is a list of counties that have joined by state on stepuptogether.org under the counties, and so you can check and see if your community is already a Stepping Up county. You can also download a template resolution if your community does want to join and hasn't joined already. Some of the resources that Stepping Up offers, we do these types of webinars regularly. We also have quarterly calls of smaller networking groups of rural, mid-sized, and large urban counties so that counties of similar size can meet with each other, network, learn about some of the solutions that are happening for like-sized counties. We do educational workshops at NACo conferences and other partners conferences. We also have a number of written tools and documents on our resources toolkit that we have a project coordinator handbook that helps you sort of walk through our 6 questions framework for how to do this work in your local community. We have other written tools, case studies, issue briefs. We also have a self-assessment tool that is online, so your county can go in and see how it's doing and some of the activities that are recommended under Stepping Up and compare yourselves to other communities. You can also get additional resources on how to implement some of those pieces while you're in the tool. So very cool tool for you. And then finally, here's the contact information for folks who work on Stepping Up. So myself at the National Association of Counties, Risa Hannenberg at the Council of State Governments Justice Center, and then Chris Seeley at the American Psychiatric Association Foundation. So please feel free to reach out to any and all of us at any time if you have questions or about stepping up. Next is Data-Driven Justice. And so Data-Driven Justice is a project of the National Association of Counties and Arnold Ventures that really aims to break the cycle of incarceration by using data-driven strategies to improve how the justice system responds to people who are frequently utilizing health, human services, hospitals, housing, and justice services. So we know that in any community, there's sort of a small number of folks who have chronic physical conditions, mental illnesses, substance use disorders, maybe experiencing homelessness, who may be cycling in and out of different systems like jails, hospitals and emergency departments, detox facilities, your homeless shelters, crisis centers. They're the ones who probably are frequently getting calls for service from law enforcement. And sort of what we see is that all of these systems that these different folks are touching are sort of fragmented and not working together to holistically address the needs of some of our most vulnerable residents. And so we started Data-Driven Justice to really provide tools and resources for cities, counties, and states that are looking to do something different with this really vulnerable population of frequent utilizers of these services. We have about 145 communities that have joined Data-Driven Justice so far, still recruiting additional communities to be part of that. We do have a website on NACo's website for Data-Driven Justice where you can go check out the resources, fill out a contact form to get your information so that you're on our email list, and you can also download a letter of interest to join the initiative. Some of the resources that we have, we've got a playbook to help sort of guide you through, what are some of the key questions that you'll need to address as you're thinking through building a project around data-driven justice. We do quarterly webinars on some of the best practices. We do case studies, we do educational workshops. We have an online resource library with things like sample MOUs or, templates that other folks can download. Issue briefs, partner resources, all of that kind of stuff is available on the Data-Driven Justice website and publicly available to you all as well. And then if you want to contact us to get more information about Data-Driven Justice, or you have questions about some of the resources that we have available, you can reach out to Sharon Ondeji from NACo, whose information is up on the screen as well. So that was a quick and dirty. I wanted to spend more of our time, especially because we sort of went through these on the last webinar, hearing from our speakers today. And so we're really excited. We have 2 counties who are going to be presenting today, starting with Lane County in Oregon. So we have Ms. Danielle Batista, who is the Program Services Coordinator for the Lane County, Oregon Human Services Division. In this position, she helps lead the Frequent Users System Engagement, or FUSE initiative in the county, if you're familiar with FUSE. Prior to working with Lane County, Ms. Batista worked for Cornerstone Community Housing as the Housing and Healthcare Coordinator, where her main role was to develop and maintain strategic community partners to integrate affordable housing into the community of care, planning, and policy discussions within Lane County. So I am going to go ahead and hand it over to Ms. Batista.
Great, thank you. Thanks for the introduction. So I am going to give an overview of our FUSE initiative, as she said, and how we use data to identify our highest utilizers of crisis systems. Next slide. Okay, so a little overview about Lane County. We have a population of nearly 375,000 people. 16.6% of that population is below federal poverty level, which is below state and national percentage. And the median family income is roughly $50,000. Over half of our renters and 32% of homeowners are housing cost burdened, meaning they spend more than 30% of income on housing. We have a wide geographic coverage with 85% of forest land. Primarily, homelessness is concentrated in the Eugene-Springfield metro area, and homelessness has increased in Lane County as it has on most of the West Coast. And according to our 2019 homeless point in time count, which looks at people who are experiencing homelessness on a given night in January, and there were 2,165 homeless individuals counted, and 1,683 of those were unsheltered. And so because we have such a high unsheltered population, the homeless population is pretty visible in Lane County, and it impacts so many of our community members. So we realized that we need a multi-sector community response if we're going to make a dent in improving the situation. Next slide. So in 2016, Lane County looked to the Corporation for Supportive Housing's FUSE model as a strategy. So FUSE, if you're not aware, is a signature initiative of CSH, and that has helped communities implement the high utilizer, frequent user supportive housing initiatives. And there are three main pillars that are at the core of FUSE. So the first one, which is what I'll focus on for the duration of my presentation, is really looking at using data to identify a specific target population of high-cost, high-need individuals who are shared clients of multiple systems, such as the jail and other crisis health services, and whose persistent cycling indicates the failure of traditional approaches. The second pillar, policy and systems reform, is really looking at public systems and policymakers who are engaged in collective effort to address the needs of shared clients and to shift resources away from costly services and more towards cost-effective solutions around permanent housing and supportive services. And the last pillar is targeted housing and services. So that is that supportive housing, permanent housing is linked to individualized supportive services, and it is enhanced with targeted and assertive recruitment through in-reach into jails, shelters, hospitals, and other settings in order to help obtain housing stability and avoid returns to costly services and institutions. Next slide. So a little how we implemented in Lane County. So in 2016, when we worked with the consultant, we were on board with the FUSE model, and we realized as we needed this system collaboration, and we realized we would achieve this by the cross-matching data for our frequent users and shared clients. And once we could identify that target population, we decided to implement outreach, or better yet, this in-reach, to this group of high utilizers and really work on engagement. From there, we would identify what their barriers were to housing and then try really hard to get them into any housing option, but primarily into supportive housing, where they can be connected to intensive case management. So as a result, we hope to achieve better outcomes. We wanted to see reduced recidivism, reduced ED visits and hospitalizations. We wanted to improve the quality of life of these individuals who are highly vulnerable and improve their health outcomes. And we also, as a cross sectors, want to reduce inefficiencies and cost savings by breaking the cycle of crisis. Next slide. So just a side note, the one significant part of the FUSE model is housing first principles. So housing first means that issues that may have contributed to an individual's homelessness can best be addressed once they are housed. So we know that it is incredibly challenging for people to address issues with mental health, substance use, who are unemployed or underemployed, or have other barriers to stability while they're outdoors or in a constant unstable environment. And then another principle of housing first is that housing is a right to which all are entitled and is not a reward for clinical success or compliance. And then the other thing is that we want to get people into housing first, but we also know that it doesn't mean housing only. So we'll need to make sure that we have the supports available to people to stay stable once they are in housing. Next slide. Okay, so here's where we get into the data a little bit. So we developed our high utilizer list, or what we call our FUSE list, using the following data points. So we looked at police arrests, court citations, psychiatric hospital nights, inpatient hospital nights, emergency department visits, jail bookings, and we also looked at bans from public transportation and then bans from emergency shelters, which were more indicative of someone's behavioral issues. Next slide. So how we got the data. So obtaining the data was a process. So first we created a FEW steering committee, and that was comprised of representatives from 2 jails, 2 police departments, 2 municipal courts, 2 hospitals, 1 Medicaid health plan. We had fire and EMS, and we had Lane County Behavioral Health, Lane County Human Services Division, and the Public Housing Authority, all part of this steering committee. So each one of them, as part of this committee, held a leader position within their organization, and they were able to designate an analyst from their organization to help us with the data. So I can't express how important it was that we had data stewards as part of the steering committee. So they were into the data. Lane County Human Services Division, which is where I work, is the convener and data keeper of the FEWS data. So because of our structure and that we are embedded within the county, we are really poised to work with multiple entities. So we already manage the Homeless Management Information System, so we have access to emergency shelter data and other homelessness data. And Lane County also has a federally qualified health centers and behavioral health within the county, so therefore we had an existing relationship with the Medicaid Coordinated Care Organization. So this Medicaid health plan was ultimately the agency that provided the healthcare data to us. And the jail's also part of the county, so that we were natural partners in this. Fortunately, the police and court data was pretty easy to obtain. They were pretty willing to give this information because they kept arresting and seeing the same folks. So they wanted another intervention and we're excited to be a part of it. And then Lane County Health Human Services held data sharing agreements through MOUs with all of the participating agencies. So one challenge that we did have is that we didn't get any data from the hospitals right away, and primarily because of concerns around client confidentiality. And while we knew this would create gaps in our understanding of the shared population, we decided to move forward with the information we had. So over time, with some relationship building and further discussion of data sharing agreements, we were able to get one hospital at least to share the information. Next slide. Okay, so here's the fun part, analyzing the data. So each participating agency sent a list of names of their top 50 utilizers in the last 12 months. So this is what we called as their primary list. And then each agency really decided on what the threshold would be for their high utilizers. So we didn't tell them to define it. We just asked them, send us your 50 utilizers and we'll kind of look what that threshold is from there. We then took each of their lists and cross-referenced each one to create one master list. And so that master list ended up being about 275 people. So from the master list, we asked agencies to provide additional information on clients who were not on their primary list, but were showing up on the other agency list. So we called this their secondary list. We then had to narrow the list by creating a ranking system. So essentially, the higher the number of system contacts, so number of arrests or ED visits, et cetera, the higher the ranking. We also accounted for how many systems someone touched, and our office would determine someone's homeless status. So we initially asked our partners to only send their highest utilizers of unhoused individuals, but some agencies didn't collect housing status, or they had outdated or different definitions of homelessness, or more commonly, we found that they determined homelessness by someone's address, which we found was often inaccurate. So we would do that on our end. And if we were uncertain if someone was homeless or not, we would keep them on there, and we would, once we make contact, we would go from there. Next slide. So we narrowed our FEWS list to our top 100 utilizers. And so here's a breakout of what it looked like. So 73% of the 100, so 73 of the individuals were high healthcare utilizers. So at minimum, they had a combo of 16 or more ED visits or hospitalizations. But we had one individual who had high as 100 ED visits in 1 year. We had 88% of them were frequent arrests, so that means they had 7 or more arrests in 1 year. Over half had 5 or more jail bookings, and 30% had 5 or more court citations, and then 78% were banned from emergency shelter. And we really only have one main emergency shelter in town, so if they were banned from there, that meant they were going to be unsheltered. And then a third of them were banned from LTD, which is our public transit. Next slide. Okay, so now we have the top 100 fuse list. We shared this fuse list with our community partners, and we had an outreach team and a housing team. And so right now these are under 2 different agencies doing outreach and housing. So the street outreach or inReach, their primary goal is really to work on engagement. It's trying to work with folks, and they would meet them where they are, so that whether that was in the hospital, in jail, or in the field. And they would provide assistance with reducing barriers to housing. So sometimes that meant obtaining documentation, so either getting birth certificate or Oregon State IDs. They would do mobile front door assessments for our coordinated entry system, which is essentially the entry point into supportive housing. They would provide transportation either through bus passes or through what we have in our community's right source, or they could even transport clients themselves. And then they connect people to mental health, substance use, and physical health services. So they could take someone to their appointment, they can help them do a screening and get to their intakes. And then they would also connect people to mainstream benefits such as SNAP or Medicaid or other benefits. The housing side, we have 3 different housing sort of interventions available. One is rapid rehousing, which is more medium-term rent assistance up to 24 months, and they get some case management. Permanent supportive housing is going to be more intensive case management with folks with a higher vulnerability, and it's going to be a longer-term rent assistance. And then we also have a Section 8 preference with our housing authority, and which also comes with case management. So the housing team, they help with housing search, and really the primary goal is just to keep people in housing. So really focusing on how they can be a good tenant, and how to connect them to other support services within the community. And they would often be the liaison with the landlord and the client. Next slide. So I wanted to bring up case conferencing because this is sort of where we could test whether or not the fuse list matched who our partners are seeing as high utilizers. So if no one knew who someone was on this list, then we knew we would need to take a look at our prioritization method. But what this looks like is there's really 2 different case conferencing groups. The first one is a biweekly case conferencing between our fuse core team. So this is our street outreach and housing programs. And this case conferencing focuses on resolving barriers to housing and to obtaining and maintaining housing. The second one is a monthly community case conferencing with our community partners. So this focuses on developing a shared care plan where we developed our fuse ROI that all our steering committee agreed upon, and it was a process to get that. But it includes all our fuse partners on there. And then here we use our data to help us understand which system someone is touching, and then we as a team try to identify other strategies that our community partners can help with to help reduce some of that utilization. And we also try to track other things within those meetings and use that information if there are consistent barriers that clients are facing, then we can use that for quality improvement purposes. So one thing we noticed, for example, is a consistent barrier to housing was people didn't have IDs or we had a hard time contacting them. So we used that and developed better flagging systems. And then we also, a simple thing is that we could pay for phones for folks. So we gave them phones and outreach team could stay in contact with them, and that has helped the engagement process quite a bit. Next slide. Okay, so in summary, our cross data match really highlighted the number of shared clients that we had. And this really accelerated our ability to collaborate, not just at a leadership level, but at the direct service level. We did a lot more work on case conferencing between agencies who never really talked to each other before, but now are really focusing on looking at a client more holistically. So the data, again, allowed for more targeted outreach and coordination across these different agencies. It gave us more focus too. The other thing is that we didn't get all the data that we wanted. So for example, we didn't get the hospital data, but we were able to get buy-in over time after demonstrating the value of providing more holistic approach for our shared clients. So I want to emphasize that most communities likely will not get everything that they want, but over time, I think your partners will want to participate as they start seeing positive outcomes. And then the last thing I'd say is that it's really critical to have the right people as steering committee members, and they really need to be your data champions moving forward. So I'm really excited about this project because it not only it's improving the lives of these really vulnerable populations, but it has grown quite a bit since we started. And it's grown because we've been able to demonstrate outcomes through data. We've been able to show that we can't work in silos, that is going to be ineffective. So I appreciate the opportunity to speak today. Thank you.
Great. Thank you so much, Ms. Batista. Really interesting presentation. I know you guys have been working on this for some time, and you got a ton of questions. So we'll just a reminder to folks that we'll be doing Q&A at the end of the second presentation, which we're getting ready to start right now. So thank you again. So I'm going to introduce our second set of speakers who are from Bernalillo County in New Mexico. So first we have Dr. Sam Howarth, who is the Behavioral Health Administrator for the Department of Behavioral Health Services in Bernalillo County. He oversees quality assurance and quality improvement, performance management, and program development for the department. He also manages the county's Law Enforcement Assisted Diversion, or LEAD program, and represents the county on data sharing project that includes figures on criminal justice, law enforcement, and behavioral health. And then joining Dr. Howarth is Dr. Michael Hess, who is the statistical analyst for the Department of Behavioral Health Services in the county. He manages in-depth examinations and interpretation of data across the department's many behavioral health programs. He implements new ways of gathering data from these programs and the department's community partners, and he oversees data and record management. Prior to this position, he served as a student advisor to medical students at the University of New Mexico School of Medicine, in helping assist them with data gathering, management, and statistical analysis on their research projects. So thank you both for joining us today. I'm going to turn it over to our speakers from Bernalillo County. And Bernalillo County, if you guys wouldn't mind unmuting you, we can't hear you. Folks in Bernalillo County, you guys have yourselves muted. We can't hear you.
Oh, there you go. Hello?
Great. Thank you. We can hear you now.
All right. Thanks. So this is Sam, and I want to start off by offering appreciation for the prior presentation. Super impressive, and also the presentations yesterday, which is sort of a good way for me to introduce how we came to our frequent utilizer project. So about a year or so ago, I was at a conference, and I went to a session on frequent utilizers because the director of our department had asked me to think about putting together a frequent utilizer tool. And so I went to the presentation, and in essence, their frequent utilizer tool had two dimensions to it. It was either number of bookings into jail or length of stay in jail over a given period of time, 12 months or 18 months. And I thought, wow, if it's that easy, we can do that because we have that data or access to that data. So I came back, and Michael and I got together and pulled jail data from our Metropolitan Detention Center and also data from a program or programs that we administer at the county. And I'll tell you a little bit about those because it's important for the context of the work that we're doing. So here in Bernalillo County, we have a campus that we call the CARE campus. And on that campus, we have a public inebriate intervention program, which is a up to 24-hour sobering program. We have a detox program, which is a up to 10-day detox program. And then we have a supported aftercare program, which is a sober living program for people who've completed a detox program. And we get about 17,000 people through those programs a year. So we have access to that data as well. So Michael will take over for a little bit here and explain what we did with those two data sources and how that led us to look at other interesting data as well. And then I'll chime in closer to the end about other data that we anticipate gaining to further inform our list.
Thank you. Hi, I'm Michael Hess. Can we go to next slide, please? So this is a graphical representation just of some of the sources. Some of the sources that we're getting our data from, but it also has sources that we're hoping to get data from in the future. So as Sam pointed out, we started out with looking at 18 months of booking data from our Metropolitan Detention Center. When we first did the list, that comes out to, and it continues to come out to, probably about 37,000 separate bookings. So from there, what we do is we pare down the list to show only individuals. So because some people have been booked in more than once, twice, three times, up to whatever. So we pare that down just to get the individual names, and then we matched that. We matched that with our public inebriate program data and our detox data, and then pulled out those names where people who had 2 or more bookings also visited our campus and our CARE campus and were in our programs, either the public inebriate program or the detox program. What that does is basically brings it down to about, in our initial list, about to 230 people or so. And so those 230 people started out as the basis of our list. We also had some people who were left over, who didn't quite, who basically showed up, but they didn't warrant being put. They weren't as frequent, or they weren't as high utilizers, and so we started them on a watch list. And so we basically started out with an active list and a watch list based on this data. Next slide, please. So this is just the process of how we got to where we were. Once we got that initial list, then we started looking at additional data that we could use to try to, as we looked ahead, try to make active interventions with these people. So in addition to the bookings into our jail and the PIP and the detox program participation, we also looked at whether they had been in the jail's psychiatric unit in the past 18 months. and recorded that information. If they were labeled in the jail as being mentally ill or suicidal in those past 18 months. In the jail, they also do as part of the initial assessment when they're coming into jail, they're giving a risk screener questionnaire. And from that, we get a risk screener score. It's a 1 to 8 screener score. And so we looked at the data as to what their risk screener score was. And in particular, we were interested in looking at whether they fell into the high risk category of 6 to 8 on the screener score. Later on,
let me jump in real quick on the screener. The screener is a tool that we developed in partnership with the University of New Mexico that looks at really 3 things: risk of recidivism, substance use, and mental health. So the higher they score, the more likely they are to be impacted in all of those 3 ways.
The other things we looked at is if they had already been had some kind of contact with some of our other programs, including all people who are released from our jail pass through our resource reentry center, and this has been going on for the past over a year now. And so whether they got an interview at our resource reentry center and whether they got a transition plan while they were in the jail, we have partners in the jail who are working with us to identify people who might benefit from a transition plan. And so we looked at that information as well. Next slide, please. So here we just have kind of the flow chart, basically, in terms of what we've done kind of moving forward. So moving forward from that base list, now we go through we've done this for the past 8 months on a monthly basis. We go back 18 months for with the MDC data, look at match that with our detox and PIP lists, and then we basically make an assessment of the data. If the individual has touched one of our systems in the past 3 months, they are on our active list. And if they haven't touched one of our systems in the past 3 months, then they are on our watch list. So they can basically move forward, or they can move up from our active to our active list from our watch list. They can move down from our active list to the watch list. And so we basically keep track of who's doing what and how often they're touching our systems. They can also drop off our list completely. So our list always stays between 200 and 250 people. Next slide, please. An additional set of data that we began to get, it's been on an infrequent basis, but additional set of data we've been getting from our State Department of Health. We send our list, we send the names and the date of birth of the people on our list to them, and they've been providing us, when they can, the number of ED visits that each individual has. And so in keeping with this data, we've been able to develop a kind of a scoring system similar to what Danielle was describing, a scoring system where we can gauge for ourselves the severity of the utilization that's happening on our list. We've assigned basically a point system based on conversations that we've had with clinicians within our county system who work with people as to how to weight those particular touches. So some of the touches and some of our systems are weighted less, and some of the touches are weighted more. And one of the big things is if they touch the psych unit in the jail, that actually is weighted fairly heavily, though only on a one-time basis. What's happened is this score has basically given us an idea of who are our most frequent utilizers and who are less frequent but still basically manage to make our list, and also may inform us going forward as to the people who might be most open and most receptive to our interventions. Next slide. This is an example of a list, a de-identified list, in which basically only us here at the at our campus see, our administrators see, but which we also are able to use as an opportunity to share with some of our other programs, so that we can basically start identifying frequent utilizers and catching them. The top part of the list you see is the active list, and you can see that in place of name there's number, but then we have information like the date of birth, how many times they've been in our detox program, how many times they've been in our public inebriate program, bookings that they've had at the jail, number of ED visits when we're able to get it, whether they've been in our psych unit at the jail, whether they've been labeled as mentally ill or suicidal while in jail, their score, and then other data that we use to be able to decide whether the person stays on the list or off the list, including, and at the very end, we have their risk group score and their transition plan, if they got a transition plan or not. The salmon lines at the top of the salmon rows on the active list indicate whether they are currently in jail, which is important for us to know because we can have our transition planning team meet them in the jail and hopefully start the process there. The bottom part is our watch list with the same information, but these are people who have not had a touch in the past 3 months, and so therefore they are basically in our watch list. They may move up, or people from the active list may move down. Next slide, please. Here's some information just about the list. Our latest, on one of our latest lists in October, we had 247 identified frequent utilizers on our active list. There were 102 other utilizers who are on our watch list. They have not touched our systems in 3 months. And again, if they can go back and forth or get dropped off altogether, depending on whether they meet criteria or not. Next slide. Once a list is made, then we have the opportunity to share it with many of our programs. So as I mentioned, we have, or Sam mentioned as well, we have our detox and our PIP program, which are opportunities for us to share the list with our case managers there. So the way that happens is once we've identified the frequent utilizers, they have all visited this campus at some point. So we put on their record an alert that identifies them as a frequent utilizer. Then if they check into our detox or our public inebriate program, once they check in, that alert comes up and they can be diverted to one of our case managers, who can then start the process of getting them services they need, hopefully to break the cycle. We also share portions of our list with our Resource Reentry Center. This is the center where people come through after they're released from jail. It's the place that they stop first before they go onward. We can identify, or we can send the list to our Resource Reentry Center, and they can be on the lookout and possibly pull people aside as they get off the bus and walk through the building and be diverted to our case manager or a pathways navigator. We also share portions of our list with our transition planners, only the people who are currently in the jail, and they can go and begin the transition planning process with those people, particularly the ones who are high risk based on screener scores. We only share the information that is needed on those lists, usually consisting of name, date of birth, perhaps for the jail, a jail ID number, but nothing else. Nothing else is shared. The list is alphabetized too, so there's not even a sense of how severe this is. So we really keep the information to a minimum, just the identifying information that people need to get to these utilizers. Next slide. So we've been validating, because we've started this and we weren't sure exactly what we were going to get, we were hoping that we would basically be able to find that this list could be validated. And over the 8 months that we've been doing it, we found that the list seems to be validated in many ways. For instance, 82% of the people on our October list had been in the the jail psych unit, the PAC unit, in the past 18 months. 29% of them were identified as having a mental illness or being suicidal. That was our first indication that we were reaching what we thought was the right population. If we looked at the screener scores, the risk screener scores that come from their initial assessment, the risk screener score has only been being done since February, so not everybody on the list has had a risk screener score, but of the 220 who did, 89, that was 89% of our total list. 48% of those, almost 50%, had risk scores of 6 to 8. So the highest risk that the highest risk people who, and this risk meant they were at risk of basically going back to jail or using or basically utilizing again. 23% of the people on our list were currently incarcerated. And high numbers of them have visited our public immediate program or detox program, and about half of them have touched all three in the past 18 months. So we feel like our list has been validated just by looking at these numbers that we're reaching the right people. Next slide. We've done some demographics on our list as well. As you can see that we have basically very high numbers of Hispanic and Native Americans. In fact, in terms of our participation on the list or our inclusion on our list, we probably have a higher number of Native Americans, probably twice the number of Native Americans as a percentage than are in our county. So quite a bit of Hispanic and Native American representation on our list. The income shows that over half of them have no income or report no income whatsoever. So we're talking about people who have little or nothing. Most of those are most likely homeless. Next slide. And one thing that I didn't mention up there is over 74% of them had had at least one emergency room touch in the past year. And many of them have multiple emergency room touches. Age group tends toward 26 to 45. That counts for over 70%, almost 75% of our list. 3/4 of them or so are male. And as I mentioned before, the risk group, about 48% of them were high on our risk group. In fact, one of the things we started doing was seeing how many people were on our list over the amount of time that we've been doing it. And since we've been doing this list monthly for the past 8 months, almost 20% have been on our list as an active, on our active frequent utilizer list over those entire 8 months. Next slide.
This is Sam. So Michael summed up progress to date very succinctly, I think. We are currently in the process of trying to work with our managed care organizations to get their lists and to look at the overlap between their lists and our list. We have 3 managed care organizations in the county. They've all expressed interest in sharing their lists, and their lists are informed by 2 data points. One is number of emergency department touches, and the other one is total cost to the plan. So that's how we are thinking about getting at hospitalization data, because we know from experience that the hospital systems in our county are not excited about sharing data. So that's, we hope, imminent. We've already received Albuquerque Police Department's data, their list, And it's a very short list. It's only 30 people, and of those 30 people, 3 overlapped. I think it was 3 or 4 overlapped with our list. We're in discussion with the district attorney's office and the office of the public defender to see if they would be willing to share their lists. And then Michael and I will look at those various lists and see how that informs this project, and if we want to reshuffle things in some way going forward. Excuse me. Michael also talked about the Resource Reentry Center and the CARE Campus, our detox program and our PIP program. And currently, those are, if you think of them as doors, those are the 2 doors that people can go through where we see if they're on the active frequent utilizer list. We're in the process of talking with others. In fact, we're presenting to the Board of Regents at the University of New Mexico Health Science Center at the end of January on this list, and exploring the possibility of sharing that list with their emergency department and hospital system more broadly, so that they can also be active in connecting people to intensive case management. They have intensive case managers at their hospital, and we also have intensive case managers who they could refer to. So the intervention that we talk about simply is when we have an individual come through one of the current doors or one of the future doors, and they're identified as being on the list, the linkage that we make is to connect them with an intensive case manager. What we then do is we ask these various intensive case managers to provide us a monthly report of who they contacted and what the disposition was. So for example, at the RRC, and same thing with the CARE Campus, all of these services are voluntary. So last month, there were 7 people that came through the CARE Campus doors who were on the frequent utilizer list, 4 of whom wanted to be connected with services and have case management and were connected with services, 3 of whom declined it. We do the same thing for data at the RRC, and if, for example, the University of New Mexico wants to utilize the list, we would ask for the same sort of information from their case managers. So from a sort of evaluative perspective, that, and to be kind of scientific about it, that becomes our intervention group, right? So we fast forward another, say, 6 months, because we've been at this for 8 months, or another 4 months, and we look at people who were picked up by an intensive case manager in the first month, and we know what their behavior looked like prior because they got on the list, right? And then we would want to look at their behavior subsequent to receiving that case management to see if they recidivated less, if they touched our campus less, if they were in the emergency room less frequently. And we can also look, because the intensive case managers provide us, what services they got. So it can be, connected to social supports, to housing, to inpatient, to outpatient, physical health, behavioral health, the gamut. So we track that as well. So I think that's about it for us, and we'd be happy to entertain any questions.
Great. Thank you both so much. Lots of information there to share, so we appreciate you guys. And we, much like Ms. Batista's presentation, got a ton of questions. So I'm going to go ahead and start asking some of those questions. Just a reminder for everybody who asked about whether the slides and the recording are going to be available. Yes, those will be posted on both the Stepping Up website and the DataDriven Justice websites, so you can access those. You'll also 24 hours from now, you'll get another email from GoToWebinar that has the link to the recording on it as well, so you can get that. So, like I said, we have a few minutes left for questions. If folks have questions, please feel free to keep submitting those. We're not going to get to all of them today, unfortunately, but as you saw on the slides, you do have speakers' contact information. Please feel free to reach out to them with your individual questions. If we don't get to your question today, I've already gotten like 30 questions. We'll probably have time for a few. So want to start with one that multiple people submitted. And so maybe we'll start with Ms. Batista, since you went first, but can you talk about any challenges you had with HIPAA or with 42 CFR Part 2 when it came to combining these lists? And if so, how did you overcome that?
Yeah, Sure, absolutely. So we talked about that we didn't actually get the hospital data, and it didn't include the information that we did was health related was from the health plan, and it included ED visits, inpatient, number of inpatient stays and how long they were there, but it didn't include anything around if they had a substance use disorder. And our way of addressing that, because we have criminal justice partners and others in the room, our partners would only get name and date of birth when we sent that information out. And also we sort of had a smaller list for our criminal justice partners. So essentially we sent back the list of names of folks that they had submitted to us already. So they wouldn't know if they were high healthcare utilizers or not. So I still think that there is still ongoing challenges with getting the other hospital on board. But a lot of it has just been relationship building and then demonstrating that it's going to benefit their clients. So.
Okay, great. And then folks from Bernalillo County, do you guys want to respond to that as well? Did you have any challenges with HIPAA or 42 CFR, people saying, I'm not going to share my data with you because, you know, or I'm not going to share my list with you because it violates, you know, either of these two rules?
Yes, sure. We haven't had any challenges. The data that we have at the campus, we can see because we administer it. The jail data is public data, and that's how we get it. And then when we do the compilation that Michael described, we do the same thing as our counterparts. We identify it, first name, last name, and date of birth only alphabetized, and that's the list itself. So when we send that list to the Department of Health to get emergency department visit data, we send that to them and they just add a column and they put a number in it. So John Doe had 3 visits in the last 18 months. We don't know the nature of those visits. We don't know exactly when they were. So we're pretty comfortable with sharing the list, though we haven't done it widely yet, but we're in the process of moving there.
Okay, great. And sort of a follow-up to that, since we were talking about de-identifying the data, I know in Lane County you talked about the process for can you talk about at what point you then de-identified the data and who specifically did it for you guys?
So once we've compiled the full list, so we did, so it remained, when we share the list, we do share similarly. We have name and date of birth that we sent out, and it's also alphabetized. So I'm sorry, can you repeat the question?
Yeah, folks were wondering the process for de-identifying the data. So at what point do you determine that it's appropriate and feasible to de-identify that data, and then who does that?
We do that in our office. That would be before, so all of the, I should say, is that all the information coming to us has name, date of birth, and all of the information. And then we at Lane County process all of that, and then we'll share it back to our partners. But removing all of the information about their ED visits and their number of arrests, so they won't have that information. At that point is when we remove it. And we use Excel, and we just delete the columns, and it'll just be a minimal list from there.
Okay, great. And then for either of you, we got a couple of questions around technology pieces, but for your list, so you guys came up with like an original list. How often are those lists of your frequent utilizers updated? Are they updated automatically, or is it a manual process that you go through to update those lists? Maybe some people fall off, new people come on. What does that process look like? Maybe we'll start with Bernalillo County.
Go ahead.
So this is Michael. So our list up till now has been updated monthly. We started it in April. And so the first of the month, we've been starting the updating process. We will most likely go, because we haven't seen much movement, no heavy movement on and off the list. We're probably going to go to a quarterly list starting in the new year. The process of updating it is pretty technologically intensive. We need to start out with, we're working with a bunch of different data systems. So we're working with the jail data system. We have to download that data. Then we have to download data from our own system. It all goes into Excel files, which are then used to do the matching and whittle everything down to our list of 200 to 250. And then we have to go through individual other databases to get the other information that we use for our list. If we were only just providing names to our people, we could have that done probably within about, it takes me about 2 hours to whittle down those lists to the 200, 250 people who are on our active and watch lists. But because we're adding different information and we're adding information from different databases, it usually takes us about a week to compile the list before it's ready for release. So it's a pretty intensive process that's necessitated by the fact that we're basically doing it manually from a lot of different databases.
Okay, great. And in Lane County, how do you all do that?
It's a very similar process. So we update it quarterly, and all of the data comes in an Excel spreadsheet, and then we have to reformat it, get it consistent, and then we just started using Tableau, where it helps us combine the list a lot easier, and so that's sped up the process. But I'd say it does take similarly about a week to finalize this list. And then the other thing is at first it was like we had our initial list and we got that done pretty quickly, but then updating it the next quarter, we had to woo folks to get it done in a timely manner. But now we're at a point where each of the participating agencies have a report that they can just generate, and they send it automatically to us on a quarterly basis. But it is pretty time intensive.
Okay, great. Yeah, I mean, I think it's really important for folks on the phone to know, this isn't something that you guys just have like one meeting and then everybody figures out who your frequent utilizers are and then goes around it, right? Like this is something that takes a little bit of time, not just the relationship building, but sort of the data collection piece as well. I think folks were looking at, how quickly can I do this? So thank you both for giving some insight into that. One of the questions we got was around how law enforcement is involved in either in some of these meetings that you guys are having around the frequent utilizers, or how, if at all, individual level police officers are involved in helping to provide referrals or engaging with your frequent utilizers to help get them connected to services. Do we want to start? We can start with Danielle.
Sure. So law enforcement is involved. We have access to our list, but like I said, it is they don't have the full fuse list. So if they're only high health users only, they won't have access to that. But we have a downtown police outreach team, and they also have a social service agency built into that. So our outreach team actually goes and does outreach with the police with them so they can do a warm handoff. And then we have a shared ROI with law enforcement. And so we do invite them to case conferencing, which was, it took some time to get there. And, but now we work quite well with at least one of the police departments. We're still working with others in the county. So that's where we're at right now.
Great. And in Bernalillo County, I know you guys have the LEAD program. Can you talk a little bit about how law enforcement is involved with your frequent utilizer folks?
Yeah, we can. Like I said earlier, APD, Albuquerque Police Department, shares their list with us already. That's brand new. This was first time last month. We have not asked Albuquerque Police Department or the Bernalillo County Sheriff's Office to use the list yet. We're in very preliminary conversations about how we could upload the list to their CAD systems and then update the list on a quarterly basis. We've talked to Fire about that. They seem interested and seem to believe that it's relatively simple, but we haven't actually taken the next step of sitting down with APD or the sheriff to say, here's the list, can you upload it to the CAD? And then when you run across one of the people on the list, consider making a referral to one of our case managers instead of to jail, unless, of course, they need to go to jail.
Right. Okay, great. Thank you, Bernalillo County. And then Plain County, did you want to? Oh, you already talked about the law enforcement. Okay. Sorry, I just got more questions coming in as you guys are talking, so I'm trying to field the questions while I'm talking to you, so I apologize. So one of the questions that came in too is sort of a follow-up is, you know, do you guys have to get, or do you try to get any consent forms signed from any of the folks that are identified as part of your frequent utilizer piece, so that I know people are still really concerned about the HIPAA and the information sharing piece, and so one of the follow-up questions is around, you know, are you guys getting consent forms signed for any of these frequent utilizers? Danielle, do you want to start?
Sure. So at the point that we're creating the list, so we don't have consent forms signed by the clients, but we do have the privacy agreements with the partner agencies. And so, but we do have the consent form when they are wanting to work with outreach. So our partners will have this list, and they could have the client sign this consent form and say if they are interested in the FUSE program, or the outreach worker will initiate that.
Great. And then in Bernalillo County?
It's much the same as Lane County. When we generate the list, we don't have release of information. When they walk through one of the doors and are contacted by an intensive case manager, the intensive case manager will attempt, and usually is successful in getting an ROI.
Okay, great. And do either of you coordinate with your local Veterans Affairs offices on some of these folks? We know that a lot of times it's sort of they might be some of your frequent utilizers as well as some veterans. Do you coordinate with them at all on your frequent utilizer programs? Maybe we'll start with Bernalillo County. About veterans?
We do. Again, it happens on the case management side of the equation, so that when an individual is contacted or connected to a case manager and agrees to be case managed, if that individual is a veteran, they will be linked with the appropriate veteran supports.
Okay, great. And then Danielle, do you all work with the VA?
We do. So we, since we manage the homelessness management information system, we also have access to the veterans by name list. So it's a list of any veteran experiencing homelessness in the county. And so what we try to do is cross-reference those lists, and we do keep them separate. And so if we do come across someone who's a high utilizer, then we can make that referral over to the VA or other veteran programs.
Okay, great. We're sort of running out of time, so I'm going to ask you both just one last question just to sort of close this out. And then, like I said, for folks who have been submitting questions, often that are very specific to specific folks, would highly recommend that you reach out to the speakers directly to ask some of those follow-up questions that are really kind of specific. But wanted to give each of you a chance to sort of close out with any practical considerations or lessons learned, or, you know, if people in this webinar are listening and they just take away one thing, you know, from your experience that might help them, you know, make their jobs a little bit easier as they're diving into this work, any recommendations there? So, Bernalillo County, do you guys want to start?
Sure. This is Sam. I think the lesson I would share is this, is to start with what you have. And don't be worried that it's too little, it's not enough data. That's what we did. And what stopped us for a while is we thought we just don't have enough data, so we put it aside. But then when we thought a little more about it, we realized we did have our campus data and the jail data, and then we were able to get all the other data that Michael presented on. So just take the first step and look at people who are frequently utilizing whatever system or systems you have data for or can get access to easily, and then go at it iteratively and try to reach out in the way that I was just talking about. Like, we'll reach out to the NCOs and to the district attorney and the public defender and others, and build it slowly.
Great, thank you. And then Danielle, any final thoughts?
I was going to say the exact same thing around just, it's okay to start small. And you're probably not going to get all of the information that you need, but it's okay. And so start small, and then you begin reaching out to clients. And I think over time, others will see the benefit of sharing information and doing more targeted work. So I agree with what my counterpart has said.
Great. Well, thank you all so much for your presentations, and I'm sure you'll be getting some follow-up emails from folks. I want to do some quick polling questions to see who we have on the line today. So if we want to launch the first poll, so we can know from you all, you know, are you a county elected official or administrator? Are you working with health, human services, social services, homeless services, who fall into that category? Are you with law enforcement or corrections? Are you with a state agency? Or are you with somewhere else? And if you are in the other category, if you want to type in what category you fall under in the questions box, that'll be helpful to see as well. Mm-hmm. Great, thank you. And why don't we go ahead and launch the second poll? Our counties are, and who is visiting. So are you guys from rural counties, mid-sized or suburban counties, large urban counties, or are you state folks? Or are you unsure? So we always get a really interesting mix of folks on the phone, so thank you for filling that one out. All right, let's do the third poll. Great. So this question is about, have you passed a Stepping Up resolution, which I talked about at the very beginning of the webinar. We have more than 500 counties that have joined Stepping Up so far. If you're unsure, which a lot of you are, you can go to the Stepping Up website, stepuptogether.org. And if you go under the tab for the counties, it'll show you the 500 plus counties that have joined Stepping Up, organized by state. So you can check and see if your county is already a part of Stepping Up. You can also download a template resolution and share it with your county board to join the initiative if that's something you're interested in. So we've got about 40% of you who are not sure if your county is part of it. So I would encourage you to go check out the website and get your folks on board. All right, last poll. And then similarly, for data-driven justice, we have almost 150 cities, counties, and states that have joined data-driven justice. If you are interested in knowing if your state, city, county, or state has joined data-driven justice, you can go to the Data-Driven Justice website, which is NACo.org/data-driven justice. and see the list of the communities that have already joined, and you can also download the letter of interest that you need to submit in order to be part of the Data-Driven Justice Project. So we've got about 40% of you, similar, interesting, wonder if it's the same people, who are unsure about whether they're part of Data-Driven Justice. So definitely encourage you to check out that website, fill out the contact form there, and get involved with either of these initiatives, or both, which is also great. All right, we're going to close down the polls and close up here. So contact information is on the screen. Please don't hesitate to contact us if you have any questions about either of the initiatives. I would also recommend, if you want to stay connected and get future webinar notifications and other resources, that you go to the respective websites and fill out the contact forms to stay in the loop. We don't spam your email. We send out really helpful notices and newsletters about some of the great things that are happening around here. So please feel free to go to the websites and fill those out. Reach out to us at any time, and you should have the speakers' contact information as well if you have further questions about the content of their presentation. So thank you again to our speakers. Thank you for all of you for joining us today, and we hope to have you on future Stepping Up and Data-Driven Justice webinars. Have a great afternoon.